Ladies and gentlemen, thank you for attending this session. I'm very happy to have this session, which is very complementary with what has been presented just before the lunch break. My name is Dominique Laurier. I'm an epidemiologist, radiation epidemiologist, and I'm the chair of Committee 1. And I have the pleasure to co-share the session with
Kotaro Ozasa from Kyoto Prefectural University of Medicine. I'm also a member of Committee 1 and based on epidemiology.
So it's going to be a very interesting session, I'm sure. We're going to have 5 presentations, 90 minutes, and promise you're going to have a coffee break after that. So I begin directly because we have a lot of presentation, and I have the pleasure to ask Yuki Fujimichi. She's a researcher at the Biology and Environmental Chemistry Division of ICRP in Chiba, and she's going to present an overview of all the abstracts that have been submitted for this session. So, Yuki, the floor is yours.
Thank you for introduction. Okay, thank you for coming to our session. I would like to introduce an overview of the posters and videos related to this session. 21 posters and 4 pre-recorded videos in this session, related to this session. And this is about 10% of all. About 17% of them were from Asia and Pacific. Next is the keywords. The first and most notably, 60% of posters and videos are mentioned low dose and low dose rate. And second, as a target diseases for studies, there is much interest in cancer and diseases of circulatory systems, and others lifespan, cataract, skin injury, and neurogenesis. And there are various research approaches, for example, epidemiology, experiment, modeling, and project. In this slide, I pick up 2 projects of low-dose radiation research. First, the Global Register of Low-Dose Rate Research Project is the online register of ongoing and planned low-dose research projects worldwide. Then the other, Planet produces scientific information in collaboration with relevant experts and stakeholders through all Japan network. From here, all posters and videos will be introduced with ID, presentator, and keywords listed by category of research approaches. In epidemiological study, there are atomic bomb studies of cataract and non-cancer mortality, and Korean radiation workers studies included metabolic and cardiovascular diseases and healthy worker effects, circulatory disease, cerebrovascular disease, and public health. The other studies included second cancer in patients, prostate cancer, Hodgkin lymphoma, and thyroid cancer from atmospheric nuclear test by France. In biological experiments, there are studies of monkeys, long-term health risk, and mouse model of the tetra-liver exposure, and mutation rate and gene expression by cesium-137 in mice, and stem cell competition in intestinal organoids of mice, protective agents in mice and cells, in mammary cancer model by cellular dynamics, and low-dose rate effects in various cells and organoid model, and micronucleus and loss vascular in vascular and cellular cells. In modeling and theoretical and conceptual studies is here. There are studies of early onset hypothesis, LNT model, AOP and LNT model, and review of thyroid cancers in Fukushima. And then biological model circulatory systems. There are many studies related to these sessions. Thank you. Please check the posters and videos.
Thank you, Yuki. And so next is the first speaker. First speaker is Dr. Gail Warshak, Professor of Radiation Oncology and Radiobiology at Northwestern University. And she's also a member of ICRP Committee 1 and the chair of Task Group 118. Please, Gail.
Thank you. Thank you to the organizers for inviting me, and Dominique promised to keep me on time. So I'm going to talk to you about work that we've been doing on low dose and low dose rate studies, predominantly as they relate to TG91, which is still in the works. So we have, to our access, a large database of animals that were done by Department of Energy, funded by Department of Energy in the US. We have approximately 49,000 mice, over 30,000 rats, 24,000 dogs, a large number of monkeys, and many others that were exposed to every dose and dose rate of radiation you can imagine. This is the archive where we store the data sets for these animals, and anybody is welcome to come in and use the data sets or request tissues from the archive, and we will attempt to honor the request as much as possible. The databases are freely available. I'm not going to promise you that every piece of data is there yet. We're still working to put up some of the dog data, and the monkey data is not there yet, and not all the rats are up either, but we are still continuing to put it up on the website. Okay, so first I'm going to focus on some of the work we've done with long-term mouse irradiation studies. Some old data that was done by Bruce Carnes and Doug Braun when they were working at Argonne National Laboratory. They looked at life shortening. So here is the cumulative survival versus the age at death for animals that were given 0.3 centigrade per day, higher dose rate, highest dose rate. And what they drew was the data for the beagle dog are shown here. The data for the mouse are shown here. And then they put in where they thought the humans would fit in. And of course, as you decrease the dose rate, you get improved survival. This is not a surprise. They made the mouse and beagle and humans be similar in age. They came up with a way to do that statistically. But what we try to do is to apply some of these data sets to other questions that are ongoing in the field. One of those for a long time has been the question about DDREF, the dose and dose rate effectiveness factor. There were BEER7, which was a group that met in the US to look at effects, had proposed studies of DDREF, and they used for those data sets mice. How do we think about radiation protection? Oftentimes what we do is we look at what cells in culture show, we look at what animals show, and we look at what humans show. And of course, we weigh the human data the most, but there are questions we can do with mice that we can't do with people. So we re-looked at the data that they had used, and what was interesting was that when they looked at low dose rate effects versus low dose effects, they calculated DDREF. Their calculations are where these dotted lines appear. The actual data for the few experiments that existed where direct comparisons were made between high dose rate and low dose rate data are shown here for the high dose rate and here for the low dose rate. So the calculations that were coming from only the high dose exposed animals where they gathered DDREF were very, very different than when there were comparisons made between high dose rate and low dose rate studies. I hope that makes sense because it's a very important point. So that means that a lot of the protection mechanisms that were developed from that report were not really accurate. For these studies, we used approximately 120,000 mice. They came from data sets across the world, including the European radiation archives and our own. And we calculated DDREF values using the doses under 1.5 gray that were very, very large. For the acute data, we had this comparison. For all data, we had this comparison. And when we compare low dose rate and high dose rate, we had huge numbers. So we rethought this through. And we looked at animal studies from the European Radiation Archive, which again was probably about 70 or 80,000 animals. We looked at the survival data for these animals, and we were able to show that one group of mice that were given 4 gray as protracted exposures, the other group was given 2 gray as an acute exposure, and they showed very, very similar values, and they showed, wait, I think this pointer isn't working, let me show. And they also had similar dose effects under these circumstances. So this made us think about a different way to analyze the data. And when we looked, and these are the data from the male mice, these are the data from the female mice. We had some more data sets to be able to look at here for these exposures, and these suggested a DREF. We did not look at dose and dose rate effectiveness factor, but only a dose rate effectiveness factor of between 1 and possibly a little greater than 2. When we did our new calculations using this approach, this time looking at a DREF, but comparing only low dose rate and high dose rate exposed animals, we got a DREF of 2.1, so much lower than the values that we had seen, that we had reported previously, and that had been reported for the animal data in the BEER-7. When instead of looking at 4 gray, we looked at a 3 sievert limit or 3 gray limit, we had a larger value, but look at this, the error rates are much higher. Why? Because we have fewer animals to be able to look at in those studies. So this is pretty much what we've been predicting now as the value for DREF in animal systems. This set uses approximately 80,000 mice to come at the answer. We're always looking for more data sets to combine with this, so the work continues. I think I don't have time for this. I will show you that we've been also doing, these are the actual data, this is the Cox proportional hazard model for mice that were exposed to radiation at no dose rate, lower dose rate, highest dose rate, highest dose rate. And of course, the high dose rate animals are dying sooner. What was interesting was when we did this is for gamma ray exposure, this green line that you can see right here, this green line is about the equivalent dose of an animal getting a CT scan every day of its life, every week of its life for its entire life. So that's the kind of decrement you might find, and these are statistically different values. We did the same thing for neutrons, and these are, again, the actual data. This is the Cox proportional hazard model data. And you can see here that for neutrons, we did see a significant dose rate effect that was evident here. It was not as evident for the high dose rates, but for the lowest dose rates, we could actually see it as well. And I don't know how I'm doing for time, but I'll skip over the data. I want to at least mention something about the dog irradiations. So one of the things that I like to point out frequently is that what we know about external beam data cannot always be applied to what we know from internal emitters. Much of our dog data sets come from animals that were given breathed in radiation, ingested radiation, were injected with radiation, and we see many different effects. We've studied tissues from these, but these are the studies looking at the cause of death for animals that were allowed to breathe in strontium-90, cerium-144, yttrium-91, and yttrium-90. Now, this is the dose per cell turnover. So it's a different way of calculating dose, a way to think about dose from an internal emitter perspective, and the causes of death from the very high doses, high dose rates, are mostly acute toxicities. The lung cancer is popping up at later dates, and there is a pulmonary injury that is happening in between. This is mostly fibrosis that is appearing in these animals. So we actually believe that calculating cell cycle time, average dose per cell turnover, if you were to just give an external beam or what we see in the control, this is approximately where it would be. If we now expose over time, you can see that the dose changes significantly with cell turnover time. And this actually shows pretty much the same idea. But here are the data I want to suggest to you are very important here. This is the percentage of animals that survived against time, given strontium 90, cerium 144, Y91, and Y90. In the control animals are the ones that are shown in black. And there are a few examples where the black animals, the control animals, live less than the animals that were given the lowest dose rate of that particular radionuclide. We believe that this difference between internal emitters and external beam is significant. It didn't appear for strontium 90. It's not really there for cerium 144, but these are both statistically significant for the Y91 and Y90, which suggests, in fact, that there is something else that we need to consider, and we believe that it's cell turnover rate when we're thinking about internal emitters. So just determining, say, a DREF value based on or an RBE for that matter, based on a comparison of internal emitters versus external beam is probably not appropriate. So the areas that we've been considering for discussion within our RBE group, TG118, and that some of these are things we've considered also with TG91. Werner is our chair of that committee. We are considering alternatives to RBE. We're considering RBE and dose rate because we believe that those are extremely important as well. Here are the players. I need to acknowledge the people who did these original animal experiments and made them available to us worldwide. A group from my own lab, a group from Argonne National Laboratory who's helped us, and then others who've worked with us over time. Thank you very much.
Thank you, Gabe.
I can ask questions, or do we wait till the end?
So, yeah. Is there any questions? No?
Okay.
So it's very important information from animal experiments, and those rate effectiveness is also need to be evaluated in the epidemiology in the human population. So as you said, it is discussion in the TG95, and so we have to think about it on both aspects, from biological and the experimental aspect and the epidemiological aspect.
Yeah, there are things that make mice and dogs be easier than people. They eat the right food that you give them, and they don't smoke and things like that. So
any questions, Father? Okay, can we proceed next? Thank you very much again. So the next presenter is Dr. David Richardson. He is an Associate Dean of Research and Professor of Environmental Occupational Health at the University of California, Irvine. He is also a member of ICRP Committee 1. He is an epidemiologist specified in radiation effects. Richard, please.
Good afternoon, and thank you. It's a pleasure to be here. I'm going to talk about effects and dose response in occupational studies. I'm going to focus on studies which look at associations between radiation exposure and cancer. And a later talk today will discuss evidence regarding non-cancer effects. I'll go through just a few lines of evidence kind of concerning these associations. The increase in demand for uranium following World War II brought attention to epidemiologic research on miners, and the exposures in the early years of the mining industry resulted in large excesses of respiratory disease mortality. On the left, there's early epidemiological publications on health and mortality of uranium miners employed in the US Colorado Plateau and in the Czech mines. On the right are two highly influential reports known as the Beer 4 and Beer 6 reports of the US National Academies that summarized evidence and provided pooled analyses of lung cancer among miners. This included uranium miners as well as tin, iron, fluorspar miners. The take-home message is these early epidemiological cohort studies focusing substantially on uranium miners have come to play a major role in establishing that exposure to radon and progeny causes lung cancer. A recent extension and expansion of those efforts is what's known as the PUMA study, a pooled uranium miner analysis study, a collaborative effort of Canadian, German, French, Czech, and US investigators. PUMA was motivated by, in part, the large increase in information since the Beer 6 report, coming from updates of many of those cohorts that had previously been examined, as well as the addition of a large new cohort which came out of Germany, known as the Vismut study. PUMA encompasses over 4 million person-years of observation and nearly 52,000 deaths among miners. It was also motivated by scientific questions that would be difficult to address in any one specific population. Questions about what are the effects of exposure to radon progeny on endpoints other than lung cancer, for example. I'll briefly note in the study there's a 5% overall excess in mortality, so there's not what's sometimes known as a usual healthy worker effect. The mortality is in excess, about 5%. Cancer mortality is in excess, 23% overall. This is due primarily to a large excess of lung cancer, more than twice what's expected based on the general population rates for these different countries. But there are other excesses of cancers as well, cancer of the stomach, the liver, the larynx. This table compares the results of this recent PUMA study to the earlier National Academy's Beer 6 report, which was a model for the effect of radon exposure on lung cancer, allowing that it may vary with time since exposure, attained age, and exposure rate. The left-hand column is reporting the parameters that are estimated from the PUMA study, and the right-hand column is reporting the results that were reported in that earlier National Academy's report. The top row is the summary excess relative rate per 100 units of exposure, 100 working level months. You can see that the PUMA estimate is similar to, but somewhat smaller, so lower in magnitude than the earlier estimates that came out of the Beer 6 report. This is largely due to the influence of the German Vismut cohort. The next rows show that the temporal factors are similar to what was reported in the Beer report. The association between radon exposure and lung cancer diminishes with time since exposure as time proceeds. It diminishes with attained age, not as quickly in the PUMA study as previously described in the Beer report, and it's diminishing with the exposure rate. The bottom row shows the amount of information in the two studies in terms of the number of deaths and the person time, and you can see that there's substantially more information in PUMA, probably triple the number of lung cancer deaths as in the previous Beer 6 report. Last little observations on PUMA. The early studies of underground uranium miners depended heavily on the information about deaths among miners who were employed in the early years of operations, when the exposures were very high and they tended to be quite poorly estimated. So we also undertook an analysis of miners who were employed in the more contemporary period of the industry, when radon exposures tended to be comparatively low. You had modern ventilation in the mines, forced mechanical ventilation, and individual exposure data was just better. This minimized these long-standing concerns that have been in the literature about the impacts of measurement errors for people who were employed in the early years of the uranium mining industry. The figure that's up on the screen is showing the relationship between cumulative radon exposure among these more contemporary miners. They were hired in 1960 or later. So the x-axis is the cumulative exposure to radon in working level months, and on the y-axis is what's called the excess relative rate. That's the relative rate minus 1. The line is a fitted regression line, a straight line for the relationship between radon exposure and lung cancer. The dots are showing you the observed data. You can see that overall there's quite a linear relationship. There's slight downward curvature, but a linear quadratic model doesn't fit substantially better than a straight linear model. And the last thing I would note is we also compared the results just using the more contemporary miners to the Beer 6 report of the National Academies. The estimates are very similar at this point. They're, again, with PUMA, they're slightly smaller than the earlier Beer 6 report, but quite compatible. So the conclusion from the miner studies regarding effects and dose response. Worker studies have provided strong evidence that lung cancer is an effect of radon exposure. The dose response for lung cancer appears quite linear and is somewhat steeper when using more contemporary data than using the earlier data. Future work in PUMA, which is ongoing right now, will help us to address questions about cancers at sites other than lung. So far we've been focused on the lung cancer analyses, and we'll move on to address those other questions shortly. Turning to another line of evidence regarding radiation exposure and cancer derived from occupational studies, reports on cancer among workers in the nuclear industry began to appear later than the evidence from the uranium minings. In the 1980s, there started to be a series of publications on large nuclear cohort studies. This began with reports, for example, on the Hanford cohort in the United States, Oak Ridge cohort, the UK cohorts of Sellafield and the Atomic Energy Authority, and the Canadian Atomic Energy of Canada cohorts. Initially, the literature was largely summarized qualitatively by the radiation research community. Reviews would be conducted, conclusions would be drawn about the coherence or consistency of the evidence, and it was largely noting the imprecision of the individual study results, often with confidence intervals that were spanning each other and spanning the null. By the late 1980s, there started to be efforts to combine information, first within countries, in the US led by Ethel Gilbert, combining Hanford, Oak Ridge, Rocky Flats, and in the UK, Valerie Barrell and Jeffrey Rose began pooling the UK data. The International Agency for Research on Cancer in France took the lead on a large international coordination of not just pooling nationally, but pulling internationally the data together to begin to get a better coherent summary of the evidence. In recent years, building off of that effort, the largest pooling efforts that have involved international collaborations are partners from France, the United Kingdom, and the United States, and something which is called the INWORKS study. It was undertaken to strengthen the direct assessment of risks from low dose rate exposures to penetrating forms of radiation. The study includes over 300,000 workers. It encompasses 10.7 million person years of observation, and it has observations now on over 103,000 deaths among the workers in this industry, 31,000 of which are deaths due to cancer. Very briefly, to summarize some of the results, INWORKS is quantifying the relationship between the cumulative exposure to ionizing radiation as measured by the personal film badge dosimeters or thermoluminescent dosimeters the workers were wearing. The values in the table are summarizing the slope of the relationship between different categories of cause of death and the rate at which they occur and cumulative exposure to radiation. So this again is an excess relative rate. That's the relative rate minus 1. That's a proportional increase in the cancer over the baseline rate per unit dose. So a value of 0 would indicate no slope to that relationship. The first row of results indicates that on average, cancer mortality increased about 53% per gray. The second row shows that after dropping the leukemias out of the analysis and the lymphomas, the estimate is just very slightly reduced. The third row is a way of indirectly assessing the question about potential confounding by smoking. So we excluded lung cancers from the broader category of all solid cancers and examined whether the association persisted. If the association was driven by smoking rather than radiation, then we would expect a large drop in the association when we dropped the lung cancers out. We didn't see that. And the last row is another way of getting at the similar question. It's looking at chronic obstructive pulmonary disease, a category of cause of death which is strongly related to smoking but not presumed to be substantially driven by external exposure to ionizing radiation at low dose rates. And we see minimal association with that outcome. This picture is a picture of the cumulative exposure on the x-axis and the relative rate on the y-axis. The dots are the observed data, the observed over expected events at different categories. There's a straight line fitted. This is a summarization of the average change in the rate per unit exposure. You can see again, there's slight downward curvature to the association. The addition of a parameter for the square of dose led to a modest improvement in fit, but not a substantial improvement in fit. If we consider the restricted ranges, one of the questions in these studies is, are the low-dose associations being driven by outliers at the higher exposures, for example? If we drop out the higher exposures, the slope does not diminish. It's not entirely driven, and that should be obvious from the graph. In fact, it slightly increases, and this is consistent with this evidence of some downward curvature. One other observation I'd point out is, while we're talking about the excess relative rate per gray, the vast majority of the information in this study concerns the low dose range. 98% of the events are below 200 milligray cumulative exposures. In that range, the fitted line is predicting a relative rate, as you can see, of about 1.1 at 200 milligray exposures. If we restrict down the data just to looking at the 98% of the data that are in the range 0 to 200 milligray, a fair comparison might be to look at, well, what would the association be there? The slope is slightly bigger, but the predicted model is about a relative rate of 1.2. So somewhere in the ballpark between 1.1 and 1.2 as the estimated associations. This is summarizing that. The slope, as we exclude the higher dose rates, is going to increase, consistent with downward curvature. The widths of the confidence intervals are going to expand, but I would direct you, as you're looking at information restricted at lower dose range, to begin scaling your inference to predictions over the dose range for which we have data for those comparisons. We investigated the impact of internal depositions as a potential counter-explanation for the observed associations, where we're focusing on the external exposures. This is results dropping out 15% of workers who ever had indications of internal deposition. The association is similar, it's slightly larger. Another way of looking at this was to exclude the sites of lung, liver, and bone as well. And again, similar point estimates. Lastly, workers employed in the early years of the industry were hired into a new industry that was created during World War II. Large numbers of healthy workers were selected out of the workforce at that time by military conscription, and there was screening into military conscription. This has led for a number of years to interest or concern about differences between the early workers and the later workers. They also have very different baseline mortality patterns, potential confounders in industrial settings in the early years of operations of the industry, and of course, questions about the performance of these very early dosimeters and other radiation control practices. Again, to address concerns about potential biases related to selection, confounding, or measurement error problems associated with the very early years of the industry, and whether that was substantially explaining the observed associations, we performed sensitivity analyses in which we dropped out the very early workers and then looked at the evidence of association. This is the results for major categories of outcomes that we looked at, summarized as the excess relative rate per gray, when we exclude workers hired before 1958 and then excluded workers hired before 1965. The associations persist. They're somewhat larger in magnitude, and it's again coherent also with dropping out some of the higher exposures and looking down at the lower exposure range. I'll wrap up by saying minors studies give us strong evidence of excess lung cancer with a dose response that's quite linear. Worker studies are beginning to provide evidence of associations for broader categories of solid cancers. The dose response is quite linear. The excess attributable cases in the worker studies are quite low because the distribution of doses is highly skewed towards the low side in the cohorts that we're studying. So very small numbers of excess attributable cases. The large pooling studies have been necessary to give us the statistical precision to begin to make these summarizations, and that frees us up to begin to turn our focus towards questions of confounding, selection, and measurement error, which are not statistical precision questions anymore, but structural questions about possible sources of bias. Thank you.
Thank you, David. Thank you, David. Sorry, we are a little bit behind, so the question, the last session. Next.
Yeah, we are going to have a few minutes at the end of the session to ask a question to all the different speakers. So we remain in the field of epidemiology, and I have the pleasure now to call Ritsu Sakata. Ritsu is the acting chief of the Department of Epidemiology at the Radiation Effect Research Foundation in Hiroshima. Ritsu, the floor is yours.
Good afternoon. I'm Ritsu Sakata from Radiation Effect Research Foundation, ICRP. I would like to thank Drs. Laura and Ozasa for giving me this opportunity to make a presentation here. Today, I would like to talk overview of recent Radiation Effect Research Foundation ICRP research activity in epidemiology. The Radiation Effect Research Foundation has continued follow-up of the atomic bomb survivors for more than 70 years, taking over from its predecessor, the Atomic Bomb Casualty Commission. The atomic bomb survivors cohort consists of 93,000 atomic bomb survivors and 27,000 residents of the cities of Hiroshima and Nagasaki in the 1950s, and who were not in the cities at the bombing. Follow-up for mortality has been continued from 1950s, and reports have been prepared almost every decade. The latest mortality report is Report 14 by Dr. Ozasa et al., published in 2012. The information of survivors' cancer incidence have been collected from 1958 through cancer registries in Hiroshima and Nagasaki. 3 comprehensive reports on the cancer incidence risk for survivors have been published to date. The latest cancer incidence report was published by Grant et al. In 2017. The result of the recent cancer incidence study, including several papers published following the main paper, were presented in session 16 by Dr. Brenner. Subject of the adult health study, a subcohort of LSS have taken health examinations once every 2 years since 1958. Reports from the AHS have also been prepared, and 8 reports have been published to date. Some of the current results from AHS will be discussed in the satellite meeting on November 11th in Shizuoka. Dr. Hida will present on cataracts, and I will talk about the mortality study because the result of AHS and cancer incidence of LSS are being presented in other sessions. We also follow up on survivors who were in their mother's wombs at the time of the bombings, called in utero exposed, and a cohort of survivors' children who were conceived after parental exposure. I won't address results from these cohorts in my talk today. This graph is a schema of the number of deaths over time due to atomic bomb radiation exposure. The number of excess deaths from leukemia increased after the bombings and peaked after 5 years, and then decreased thereafter. Excess deaths from solid cancers began to increase starting around 10 years after the bombings, and these increased risks have continued throughout survivors' lifespan. Radiation effects on neoplastic diseases are well known and have been observed in other populations, while excess risks have recently been observed for some non-neoplastic diseases. This table shows the result of the latest mortality study, report 14 by Dr. Ozasa et al. Significant excess risks have been observed for circulatory disease and respiratory disease, as well as for all solid cancer and leukemia. The point estimates of 6 averaged excess relative risk are 0.11 for circulatory disease and 0.21 for respiratory disease. The magnitude of radiation risks for these non-neoplastic diseases is small compared with that for neoplastic diseases with 0.47 for solid cancer, and excess relative risk of leukemia is 3.1 at 1 gray based on a linear quadratic model. The analysis of the follow-up period divided into an early period shown with dashed line and a late period shown with solid line essentially do not indicate an increase in risk below around 1.5 gray for the early period, while showing an approximately linear dose-response relationship for the late period for non-neoplastic diseases as a whole. The difference in shapes is significant between the period. Among non-neoplastic diseases, circulatory disease do not show a difference between the period, but both respiratory disease and digestive diseases show marginal differences between periods. The risk for digestive disease was not significant for the entire period. However, in the analysis divided by follow-up period, a significant risk increase has been observed in the later period. Risk below background risk observed in the low dose range may reflect socio-demographic factors such as urban-rural differences. It is suggested by a baseline mortality for non-cancer diseases for proximal survivors that is 15% lower than that for distal survivors. And the difference decreased to about 2% in the late 1960s. This urban-rural difference is lessened because of the modernization of the Japanese lifestyle and urbanization of areas surrounding the cities. These risks observed for non-neoplastic diseases are considered to have been observed in the later period due to diluted differences in socio-demographic factors. In the high dose range and for neoplastic disease risk, the significance of the survivor's exposure to radiation indiscriminately increases, and other factors have less influence on the relationship between radiation dose and health effects. In the low dose range and for non-neoplastic diseases that have complex etiology, it is necessary to consider confounding and the bias of other factors on the relationship between radiation dose and health effects. The influence of non-radiation damages on the atomic bomb survivors, such as damage to housing, loss of family members, and trauma from the heat and blast, varies significantly with distance from the hypocenter. This makes it difficult to separate from radiation dose that is strongly correlated with distance from the hypocenter. In the LSS, the radiation effects for non-neoplastic diseases need to be investigated, considering non-radiation factors, and the obtained results must be interpreted carefully. This is a summary of my talk. LSS has provided valuable information on radiation risks for neoplastic diseases and some non-neoplastic diseases. The magnitude of radiation risks for non-neoplastic diseases observed so far is relatively small compared with that for neoplastic diseases. The etiology of non-neoplastic diseases is complex and includes relationships with lifestyle factors and socio-demographic status. It is difficult to separate health effect of airborne radiation exposure and non-radiation damage, such as poverty and loss of family on survivors' lives. There are many factors that need to be considered when studying the result of non-neoplastic diseases, and careful interpretation of the result is essential. Thank you for your kind attention.
Thank you very much for this very interesting presentation, a very important cohort, and for respecting precisely the timing. So we have time for 2 questions, I think. Please don't hesitate. Yeah, please.
Hi, I asked a question because I'm sitting right near the mic. Just a quick question. The dose response curve for lung cancer diseases, is there a particular reason why you break on the year 1965? As first question. Second question is, what's the statistics method you use to decide this significant difference between the 2 curves? The first question is why you break up at 1965. That's okay. I just, maybe some, dose estimated, early on, I don't know.
So I'm sorry, I don't have clear answer for how the period was decided, but after the World War II, the Japanese lifestyle is rapidly changed, and the middle 60s is made big change for the lifestyles. Then, and the follow-up is started from 1950. Then, some period is needed to compare the previous and after some period. Then, probably that is some reason of the cutting point of that using 1965, I think so.
Yeah, thanks. If you can go back very quickly, the curve, the dose response, I'm just curious how you decide statistical significance, because the last one sounds like very different. If you can go back to the curve. Yeah.
This one?
Yeah, I'm wondering what kind of statistics method you use to decide significance.
The comparing these two periods.
Yes.
Yeah, that is so we compared the model fitting of the for the total period, and when we use the separated period, for example, for the whole total non-cancer diseases, the model fitting is significantly better than when we use whole period than when we use separated period than using whole period. That is a method to compare the model fitting.
Thank you. Thank you.
Is it okay?
Ritsu, can I explain more? Okay. This is my paper, so I added something. Actually, this is the kind of the time period analysis. As you know, the response shape is changed during the follow-up period. So this is a very premature. So the dichotomous period between earlier period and later period divided by the 1965 or so. So this is not so meaningful, but more detailed continuous change of the follow-up period is more important. And so it's the additional explanation. Thank you very much.
Okay, so if there are no additional burning questions, and again, we are going to have some time. Christian, you wanted to ask a question?
In the slide where you had the prenatal, that is also, you say fetuses. Fetus means you are not including the first 2 months of pregnancy.
First 2 months.
For you see, fetal period starts around
Are
2
you
months
asking?
after conception.
Yeah, are you asking about the in utero exposures? Follow-up
Yes.
of the in utero exposures?
Yes.
So the whole survivors, they possible to the subject who born after
I
the
was only astonished that you apparently do not include stages of embryogenesis. The first 2 months are not fetus. Fetal period starts around at the end of the first two of the second months.
So in utero survivors cohort include the subject babies, person who born after the bombing, from after the bombing to May 1st, 1950.
I understand this, of course.
Then all
I only was astonished you say fetuses
fetus.
and not including embryogenesis. Okay.
there was a very interesting session yesterday on the effects of in utero exposure and hereditary effects. And so I think the recordings will be available very soon. So, and I think we're going to have answers to your question, Christian, in that records. Okay. I propose we move now to the next speaker. So I have the pleasure to invite Nobuyuki Yamada. Nobuyuki is a senior research scientist at ICRP. Is the co-author of the ICRP publication 152 on detriment, and is currently on 3 ICRP TGs, and is going to speak about non-cancer effects of radiation exposure. Nobuyuki, the floor is yours.
Thank you very much. First of all, I'd like to thank ICRP, Dr. Laurier, and others for inviting me. Pleasure to be here and give a talk today. How I can... Yep. So over the past century, ICRP has revised radiation effect classification systems, and since 1977, which is based upon whether or not the effects are of stochastic nature or not. So in 2011, ICRP classified cataracts and DCS as tissue reactions and recommended a nominal threshold of about 0.5 gray to the lens for severe cataracts, and heart for cardiovascular disease, and brain carotid for cerebrovascular disease, all independent of dose weight, assuming that there is no dose protraction effect. The visual impairing cataracts are assumed to occur in 1% at greater than 20 years after exposure, and so are DCS, but at greater than 10 years. So for visual impairing cataract, ICRP has recommended dose limits. And for DCS, recommended a threshold, but as a precaution to medical practitioners because due to uncertainties and mechanisms and target organ tissues. So in publication 1, ICRP considers that the lens is among the most radiosensitive tissue in the body and the eye. In high sensitivity to low LET radiation may involve abnormal proliferation and differentiation of lens epithelial cells, oxidative stress, denaturation of lens proteins, etc. On the other hand, for the high LET radiation mechanism, additional mechanism may involve a low oxygen content, cellular quiescence, and high nitrogen content. So there have recent epidemiological developments. Because of the time, I can highlight a few studies. So in the AHS, so increased risk of cortical cataracts has been observed only at a certain time point, and a new paper is expected to report the results of the updated analysis. And the MAC workers, so this is chronically exposed Russian nuclear workers, observed increased risk at above 0.25 Cbel for all 3 types of cataracts with greater risk for PSC cataracts, the posterior subcapsule. In the US Radiologic Technologies cohort, the risk for self-reported cataracts increased significantly below 0.1 gray, but not at 0.05 gray. And in the residents of high natural background radiation area in China, the significantly increased risk for PSC opacities with no threshold, and for cortical opacity with threshold of 0.14 gray. So increased risk has so far been observed for 3 types of cataracts, with PSC cataracts more strongly associated than cortical and nuclear cataracts. So for cataract surgery, significantly increased risk has so far been observed only in the AHAs, and it remains unclear why there is such inconsistency, and the likelihood of cataract surgery depending on various factors, and cataract surgery is an imperfect surrogate that may underestimate visual impairing cataracts. So AAH study showed greater difference in prevalence risk for cataracts and for surgery, rendering some support for progressive nature of cataracts. But ICRP reports earlier said that the minor opacities often do not progress in severity, and whether the region remains stationary depends on dose. And early atomic bomb data showed little progression in lenticular lesions. Therefore, little evidence is available to support the same threshold of 0.5 Gray for minor opacities and visual impairing cataracts, particularly following non-acute exposure at low dose. So available evidence tends to support lack of clear dose protraction effect. All lens cells stay inside the lens throughout life. The lens has little, if any, turnover, making a little protraction effect biologically plausible. And the ICRP considers that the minor opacities are a linear function of dose, but visual impairing cataracts attributable to multiple minor opacities exhibit threshold type dose response. So those thresholds tend to become less clear with longer follow-up. There may be several etiologically distinct types of cataracts, like early onset cataracts with threshold and late onset cataracts with no threshold. So it will be interesting to test whether the irradiated single lens stem cells can form a cloudy lens-like structure. There is also emerging evidence for increased risk of a normal tension glaucoma in 2 cohorts and for diabetic retinopathy in a single cohort. In summary, for the eye, so for nearly 7 decades, ICRP has always considered that the lens is among the most radio-sensitive tissues and the body and the eye. So this tenet seems to remain unchanged, but cataracts are no longer recognized as a typical tissue reaction with a clear threshold of relatively high dose. And ocular diseases on the radar include the normal tension glaucoma. So determination of the radiosensitivity of the entire eye encourages more studies on diverse ocular diseases in various cohorts. So for those who are interested in this topic, so they are encouraged to attend the satellite symposium to be held this Saturday afternoon. So I move on to the DCS. For DCS, we don't have so much clear knowledge and the answer to these remain open questions. For example, whether a threshold exists and the dose response curve, it depends on the sensitivity of method for detecting an effect, or depending on time after exposure, and whether the severity increases with increasing dose, or DCS attributable to malfunction of many numbers of cells, or DCS involve any stochastic mechanisms. So the targets needed to be identified for dose management and mitigation, and the target at the levels at the organs and the tissues may include the heart, major arteries, and the kidneys and the pancreas, and the target cells can much vary with DCS subtypes. And the analysis of the lifespan study mortality data suggests low dose effectiveness factor below 1. The meta-analysis indicated the larger risks per unit dose at the low dose. And the analysis of some cohort mortality data suggests that the dose-weight effectiveness factor greater 1, but the complicated patterns of sparing and enhancing dose protraction effects have also been observed in humans and in mouse aorta. So given the same ICRP thresholds of a 0.5 Gray for DCS and the cataract, the circulatory system can be as highly sensitive as the lens, but the mechanisms, underpinning mechanisms remain unclear and the targets remain unidentified. So mechanisms can be multiple and diverse, given range of DCS subtypes, and the particular focusing mechanistic studies may be placed on ischemic heart disease and cerebral vascular diseases. And epidemiological and biological findings may tend to support the assumed lack of a clear dose protraction effect, but circulatory system effects may not be a simple function of dose rate, warranting further studies. So in the LSS, this is a major hazard of concern for non-cancer mortality, whereas as Dr. Sakata just mentioned, increased mortality risks have also been observed for various non-cancer effects. In other cohorts, non-cancer effects on the radar include the neurodegenerative diseases such as the Parkinson's disease, dementia, Alzheimer's disease, although the impact of a childhood exposure is unknown. So broadly, between these two effect categories is becoming less clear than the pairs, and as such binary classification may need to be reconsidered. Non-cancer effects of radiation have long been known, but with longer follow-up, increased risks have been reported at a dose below 1 gray. And consideration about such rate occurring non-cancer effects would also be important for patients. On the one hand, the longer the post-therapeutic survival, the broader the spectrum of normal tissue complications of concern following cancer radiotherapy. On the other hand, such consideration is needed to justify radiotherapy for non-cancer diseases. So radiation has recently been clinically tested to treat arrhythmia on the one hand, but also reported to increase risk of arrhythmia in several cohorts. And there is a similar situation for Alzheimer's disease, and as such, an action of radiation seems to represent a double-edged sword that is detrimental to healthy tissues versus therapeutic to diseased tissue, and not only for cancer, but also for non-cancer diseases. So this is the last slide. Given the same threshold of 0.5 gray recommended for DCS and cataract, the circulatory system can be as highly radiosensitive as the ocular lens, but its underlying mechanisms are much less clear. Radiation effect classification is based on the shape of the dose response curve and mechanistic underpinnings. Cataracts, DCS, and other rate occurring non-cancer effects tend to deviate from canonical tissue reactions with high dose threshold. So given that the boundary between two effects categories is becoming obscure, the classification system needs to be revisited, for which more developments via continued studies in epidemiology, biology, and its integration will be very, very important. So consideration of later occurring non-cancer effects will also be important for patients to justify and optimize radiation exposure posed by medical procedure. With that, I now close my talk. Thank you very much. I saved 30 minutes. Sorry, 30 seconds.
Thank you very much for this very comprehensive presentation and for precisely keeping the time also. And so we have time for 1 or 2 questions. So please don't hesitate on these complex questions of risk of cardiovascular disease or cataract. No question from the room? I have one for you. You're not going to escape. So presenting the results from cataracts, I understood that finally one possibility is to consider that the classification may be different for different types of cataracts. Can you extend a little bit about that?
Yeah, so for radiation protection purpose, for simplification and the social judgment and so on, so it is very difficult perhaps to divide a single disease to different types of classification. But if we look into science, the mechanisms can be multiple. So that early type, high dose or low dose, long-term effects maybe have a very different effects. Like this maybe applies to cancer, perhaps, yeah.
So thank you very much. Question from the room? Last call. No questions. So again, we are going to have some minutes at the end of the session. I propose we move to the last speaker. And so it's my great pleasure to invite Jing Chen. Jing is the chair of the UNSCARE in Vienna. And she's going to present an overview of the ongoing and planned evaluation performed by UNSCARE. So Jing, the floor is yours.
Thank you, Chair. And thanks very much for the organized committee for giving me the opportunity to brief you about UNSCARE's ongoing and planned evaluations. So my name is Jing Chen, representative of Canada to the committee. And this presentation is jointly prepared with Anna Frieder, representative of Germany to the committee. I would like first to recall the committee's mandate, defined by the General Assembly in 1955 and expanded in 1973, which is to evaluate the latest scientific data on levels, effects, and risks of exposure to ionized radiation from both nature and artificial sources, including exposure in low dose and low dose rate range. Importantly, the committee does not advise on protection or policies for the use of radiation, which is in the mandate of other international organizations. The committee carefully make the distinction between objective science, which is within scope of work, from more subjective protection and policy matters, which is not. In the past 68 years, OnScale has published 113 scientific annexes, 1 summary report, and 5 white papers. And all reports and publications are available on OnScale website for free download. Everything is available for the public. The committee's reports form the scientific basis that underpins radiation protection and represent valuable resources for the scientific community. Countries and international organizations draw on the committee's scientific evaluations for developing protection frameworks, legal instruments, policies, and programs for using technologies employing ionizing radiation. The committee's work covers very broad areas. Concerning radiation sources and exposures, the committee since 1958 has regularly evaluated the levels of medical, occupational, and public exposure to ionized radiation. The latest evaluations of medical and occupational exposures were published in OnScale 2020-2021 report, Annex A and Annex D. The updating evaluation of public exposure to ionized radiation is one of the committee's current projects, expected to be finalized in 2024. In addition to the evaluation of radiation sources and exposure, the committee has conducted significant work to assess radiation effects on human health. In the early years, a major concern were hereditary and genetic effects, but also radiation-induced leukemia was first mentioned in OnScale 1958 report. The first annex dedicated to radiation and cancer was published in 1964. Since then, the committee has published more than 20 annexes on epidemiology and underlying mechanisms of radiation carcinogenesis. In the OnScale 2010 report, after reviewing all available epidemiological studies, the committee judged that the single most informative set of data on whole body external radiation exposure comes from studies of the survivors of atomic bombings in Japan. The question of attributability of health effects to exposure to ionized radiation was addressed in the OnScale 2012 report, Annex A. The committee noticed that it had in the past provided detailed reports on estimation of risk without presenting comprehensive information on the uses and the limitations of its estimated risk for the general readers. The committee also summarized the current methodology to estimate uncertainties in risk estimates for radiation-induced cancer in UNSCAL 2012 report Annex B. In UNSCAL 2012 report, two key questions were identified. Whether a manifest health effects in an individual or observed increased frequency of occurrence of health effects in a population can be attributed to radiation exposure. And under what circumstances is valid to infer risk or to predict absolute numbers of health effects following radiation exposure, particularly at levels and for time courses of exposure for which increased frequency of occurrence of radiation-related health effects has not been convincingly or consistently observed. The committee concluded that increased incidence of stochastic effects in a population could be attributed to radiation exposure through epidemiologic analysis, provided that inherent statistic uncertainties could be overcome. In general, health effects in population with chronic exposure to radiation at levels that are typical of the global average background levels of radiation cannot reliably attributed to radiation, mainly due to the uncertainties associated with the assessment of risks at low doses and the lack of radiation-specific biomarkers for health effects. In UNSCAL 2019 report, the committee identified 5 combinations of health effects and the radiation exposure scenarios where sufficient amount of information were available to allow a meaningful assessment of uncertainty. There are leukemia incidence after CT scans in childhood, leukemia mortality after occupational exposure, mortality from all solid cancer after occupational exposure, thyroid cancer incidence after iodine-131 intake during childhood, cardiovascular diseases mortality after exposure to external radiation. The committee conducted an extensive review of biological mechanisms relevant for the inference of cancer risks from low dose and low dose rate radiation, published in UNSCAL 2020-2021 report Annex C, and concluded that little in the way of robust data could be identified that would prompt the need to change the current approach taken for low-dose radiation cancer risk inference as used in radiation protection purposes. For radiation-induced cancer, especially for the challenges dealing with exposure at a low dose and a low dose rate, the committee defines principles and criteria for ensuring the quality of the committee's reviews of epidemiological studies of radiation exposure, published in UNSCAL 2017 report. Considering these principles, the committee reported on human populations subject to environmental exposure resulting from human activities and from nature radiation. Results were published in OnScale 2017 report. The 2017 report concluded that results of the studies of cancer risk due to radiation exposure at a low dose rate from environmental radiation did not provide strong evidence for materially lower risks per unit exposure than in studies of high radiation doses and dose rate, though the findings were consistent with a range of risk estimates. At the 65th session in 2018, the committee agreed to initiate a comprehensive review of epidemiological studies of radiation and cancer to update the OnScale 2006 report. That is one of committee's current ongoing program of work. That is the epidemiological studies of radiation and cancer was studied in 2019 and is expected to be approved in 2025. Since the 69th session in May 2022, the expert group has made significant progress in advancing drafting the scientific annex on 25 cancer sites, and in summarizing the literature review on epidemiological studies of radiation and cancer. Another ongoing project for radiation-induced cancer is the project of a second primary cancer after radiotherapy. It aims to raise awareness in the scientific and medical communities and in national authorities with respect to the fact that cancer treatment by radiation, while contributing to the effective treatment of increasing numbers of patients, may in some patients result in secondary primary cancer several years later. Non-cancer health effects of radiation were last reviewed in the OnScale 2010 report, and the cardiovascular disease was addressed in the OnScale 2019 report, the Annex A. Among 5 projects, the 5 ongoing projects, 2 projects deals with non-cancer health effects. The project of evaluation of diseases of circulatory system from radiation exposure was started in 2021. To avoid extensive overlap with the ongoing evaluation by the ICRP Task Group 119, and to avoid unnecessary duplication of efforts, an informal coordination group between OnScale and ICRP was established. The OnScale expert group will focus on in-depth reviews of scientific evidence and the considerations of the whole dose range, where Task Group 119 may focus more on risks associated with low doses and their implication for radiation protection. At the last session in June this year, the committee discussed the initial results of the literature review and endorsed the proposed structure of the evaluation and the updated timeline. The report is expected to be approved in 2025. The project of nervous system effects of ionized radiation was started in April this year and is expected to be approved in 2027. At the last session, the committee endorsed the timelines and the structure of this evaluation. 3 other projects are planned to start in coming years. They are evaluation of radiation effects on the eye, evaluation of radiation effects on the immune system, and the overarching evaluation of non-cancer effects to include acute radiation syndrome, respiratory disease, endocrine disease, transgenerational effects, and other relevant non-cancer effects. Ionized radiation is one of the best investigated noxious agents. However, in spite of decades of research, our understanding of those effects relationship, especially in the low dose and low dose rate range, is limited, or we can say very limited. The committee will continue striving to provide independent, objective, and up-to-date scientific basis for radiation safety through its ongoing and planned evaluation. So I would like to use this opportunity to thank many of you in this room who has made significant and really great contribution to committee's work. And I also want to welcome more scientists, especially young scientists in this room, to actively participate in the future on-scales evaluation. With that, thank you for your attention.
Thank you, Jing, for this comprehensive presentation. We still have a few minutes for questions to all of the speakers. So if you have questions to one of the presentation, don't hesitate. Abel, come on. Don't hesitate to ask questions. It was about epidemiology, biology, cancer, non-cancer effects. You should have some questions. Come on.
Well, thank you, Chair. I believe that there is a very close link between the paper presented by Dr. Richardson and the paper of Anscare. And I would like to link both. In the paper presented by Dr. Richardson, in the conclusions, there is one element in the original paper that has been missed. And I believe that is very relevant for what we are going to say about Anscare. In the original paper, it said in the conclusions that the summary estimate of excess relative rate, solid cancer mortality per gray, is larger than estimate currently informing radiation protection. And some evidence suggests a steepest slope in the dose response association in the low dose range. This result can help to strengthen radiation protection, blah, blah, blah. Basically, this sentence have only one interpretation, and that is the radiation protection standards are not correct, are not sufficiently protecting people. This is, I mean, if I would be a radiation worker, this is how I want to read this. Now, the radiation protection standards, which are international and which implement legally binding obligations for the countries, except few. I mean, for instance, the United States is no signature of the ILO convention, but all the others are. These standards, therefore, have a lot of legal implications. How the standards were written, based on the Anscare estimates, was absolutely decided a link between the international standards and the Anscare estimate. Therefore, if the standards are wrong, according to this paper, the Anscare estimates are wrong. And I believe that this needs a clear answer from Anscare. That can be only two. Either the paper is wrong or Anscare is wrong. And if Anscare is wrong, have to apologize and probably inform other organizations to change the standards. This is the way that I see a link between the paper and unscale. I would like to hear comments about that.
I'll take it that the question is directed to me. So I'll start by saying the intention of producing a paper is to contribute it to the scientific literature. And one hopes that authoritative organizations make considerations periodically of the weight of evidence that's published in the literature. And so one doesn't publish a paper and say, therefore, the world is changed and shaken, but science proceeds through assessment of different lines of evidence. Radiation protection is not solely based on epidemiology, it's based on evidence from cells and mechanistic studies, and hopefully a wide variety of different studies in different populations examining different lines of evidence and different ways of making those considerations. And so a large collaboration of investigators building off of decades of work going all the way back to the 1950s and 60s in the United States to assemble these cohorts, we're summarizing, digesting, hopefully giving to the best of our ability, a summarization of what the evidence is coming from occupational studies. And we believe there's lines of evidence coming from environmental and medical and the lifespan study. All of them are important. And then they go to deliberative bodies which assess that and periodically make interpretations of them. So that's how I would see it. Now, did we lay out the magnitude of the estimate reported next to the magnitudes of estimates from other authoritative studies which have been out there, and including summarizations? Yes, we did. We said that they're smaller than some, larger than others. This is where they're falling. That's the interpretation of the evidence as I would see it. I would not say we need to be into the situation where one says either our study is right and the world is wrong, or vice versa. We're in a dialogue, which is called science, and we're sharing observations.
Question? I think time is over, so, sorry, there is one.
Thank you very much for a very interesting session. The session is called Effects and Dose Response. Could I probe a bit more about dose rate response, in particular non-cancer effects as such? Can you distinguish, or do we have enough knowledge to distinguish between different effects types by dose rate effects? That's probably a question to Professor Chen or to Gail.
Okay, I'll try to answer from the animal perspective. I mean, we are right now, so you saw what we looked at. We looked at life shortening and we looked at cancer incidence. We're now looking at dose rate effects because we have this large data set of animals. Oh, and the dog data included fibrosis. So there is definitely a dose rate effect difference in induction of fibrosis, which is another non-cancer late tissue toxicity in those animals. So there is definitely a dose rate effect, but that's for an internal emitter, and I always draw the distinction between internal emitter and external beam. We've done some work looking at some toxicities in mice. Some do show dose rate effects, some don't, and I can't go much further than that right now because we have a lot more to do on that.
Thank you.
But maybe cataracts. Nabi, you want to say something?
So for cataracts, so even in natural high radiation area, as an increased risk has been reported. So for that, in the point, there may be not so very clear dose production effects, but for circulatory disease, we have no clear-cut answer yet. But at least my mouse data shows dose production effects.
Yeah, sorry to take the floor again, but...
A short one, yeah.
on Dr. Richardson's answer, which is absolutely correct for a usual scientific paper. But we have to recognize that this paper is not an usual paper. It's coming with a more or less a blessing of WHO through the Institute of Lyon. WHO is one of the co-sponsors of the international standard, which is called IIA standard and not IIA standard, are co-sponsored by all the international organizations, including WHO. Therefore, this has implications which are beyond just a normal scientific paper published in the literature and ready for criticism. I believe that there is an issue that UNSCARE have to undertake and to, because it can have very serious legal consequences. Thank you.
I'm not sure if there was a question there, but rather you had an observation that as I pointed out, historically, the organizing institution for these international collaborations has been the International Agency for Research on Cancer, which serves as a common ground because the different partner countries needed a neutral organization where the US and France and the UK could be comfortable putting large historical data sets that had both radiation exposure history information and kind of information on individual mortality information. So yes, they serve as the coordinating center. I agree. I hope it's an important study, but again, I will reiterate, it is one line of evidence in multiple lines of evidence, which I hope organizations take under consideration when they're making evaluations. And it's observational epidemiological data, as are many of the epidemiological studies that we have.
So with this, we are behind, and the coffee will be cold if we wait too long. So thank you again to all of the speakers for this very interesting session. I think it covers really topics that are of major importance for the ICRP, for Committee 1, and also for the NSCARE. And of course, we still have some questions and some uncertainties. But what we can see from what has been presented is that we have more and more evidence, even in the low dose range. And clearly, we have more and more reports, results today to consolidate the system of radiological protection. Thank you again. I think we can demerit your applause.